Hello and welcome to WorldCanvass from International Programs at the University of Iowa. I'm Joan Kerr and we're happy to have you with us. Tonight's topic is COVID care for marginalized and vulnerable populations. And in this first segment, we're going to focus on public health and the pandemic, looking specifically at mitigation, disparities, and social determinants of health. For more than a year now, we've lived through the global pandemic of COVID-19 and have become all too aware of its deadly toll. People of all ages, ethnic groups, and socioeconomic backgrounds have fallen ill, and far too many have died. But within the statistics, it is clear that certain groups are more vulnerable and tend to have worse outcomes than others. Our guest tonight will help us understand why this is so and hopefully how we can turn things around. My guests are Claudia Corwin, Director of the Iowa Global Heath Network, who is also an occupational medicine specialist and clinical assistant professor in the Department of Internal Medicine at the University of Iowa Hospitals and Clinics. Welcome, Claudia. Sokhieng Au is Interim Director of the Global Health Studies Program at the University of Iowa. Thank you for being with us, Sokhieng.
Thank you very much.
And Ashlesha Kaushik is Medical Director of UnityPoint Clinic for Pediatric Infectious Diseases in Sioux City. Also a Clinical Assistant Professor in the Department of Pediatrics at the University of Iowa Carver College of Medicine and a board member of the Iowa American Academy of Pediatrics. Thank you, Ashlesha, for joining us.
Thank you.
Claudia, I'd like to go to you first. Can you help us understand how the COVID pandemic has exposed health disparities and social inequities?
Sure. Thank you, Joan. So I'm really thrilled to be here. I'm honored to be here with all the other panelists. So thank you for inviting me. This is really such a layered question. First, we all know that health inequities are an age-old problem and that this is not new to this country. There are so many differential outcomes among racial and ethnic minorities in our country, differences in maternal health, breast cancer, cardiovascular disease, kidney transplantation, and so many more. But what I think is really different during the pandemic is that many people who do not work in health fields have been hearing and reading about the disproportionate health experience of minority groups, immigrant groups, all of the so-called invisible workers who are keeping our country afloat right now may be a bit more visible now. It's just a little harder to turn a blind eye right now, frankly. Over the past year, there has been frequent news in all the lay media about disproportionate infection rates, hospitalizations, and death. And there is tremendous complexity underlying these COVID outcomes, like pre-existing health issues, like certainly contribute to increased risk, like heart disease, diabetes, obesity, advanced age, and certain conditions may actually well be more prevalent in certain populations. And there are behavioral factors or personal choices, such as smoking or poor nutrition or obesity, that may lead to increased risk. This is all true, but this is not nearly the whole story. The bigger picture requires an honest look at more systemic factors that drive these COVID outcome inequities. And this is done by addressing the structural and social determinants of health. There are many sort of visual or conceptual diagrams and descriptions of this, but essentially what I'm talking about is comprised of nearly every domain of the human lived experience: housing quality, access to education, reliable transportation, economic stability, the built neighborhood, food or food deserts, and so on and so on and so on. Two of our very own College of Public Health faculty, Rima Afifi and Nicole Novick, wrote an elegant piece recently stating that it is imperative that we broaden our concept of at-risk for COVID and expand the definition from the biological to include these fundamental social variables. Take, for example, the primarily Latinx migrant and seasonal farm worker population that follows crop production around our country and in Iowa. These workers typically live in crowded housing with less than ideal sanitation, eat in communal settings, travel to the fields on packed buses. In this case, poor housing, transportation, and the inability to shelter from home has led to this disproportionate risk during the pandemic in this particular population. So now I want to switch gears just a little bit and talk about the racial disparities in the vaccine rollout across this country. And any one of these things you can speak about for hours and hours. So this is just sort of a brief summary. The vaccination rate for Black people is half of what it is for white people. And the gap for Latinx people is at least as wide. Again, inequities within the same social determinants of health are to blame for these disparities. On a demographic scale, Black and Latinx people often have less reliable internet access to make an appointment, less flexible work schedules to take that one appointment that's available, and less reliable transportation to actually get to their appointment. Now, there is also a national narrative that low vaccination rates among ethnic minorities is due to hesitancy and a pervasive lack of trust of the system, again, in nearly every domain. And while this is certainly an important factor and has deep roots and cannot even begin to be explained in simplistic terms, it would be too simplistic to lay the blame for this systemic reality solely on the individual's vaccine hesitancy, because this is a complex and nuanced dynamic. Vaccine hesitancy will be discussed at length a bit later in the evening, but I'll briefly mention what we're beginning to understand about migrant and seasonal farm workers. Over 80% of migrant and seasonal farm workers in this country are Latinx, and well over that in Iowa. And there is much generalized discussion about hesitancy among this huge and very diverse population. However, my colleagues and I have preliminary data and some anecdotal experience in Iowa that tells us most workers either intend to get the vaccine or are seriously considering getting the vaccine, and very, very few workers are telling us they won't get the vaccine or don't want the vaccine. And while intending to get the vaccine, that many workers have some really serious concerns and deeply rooted worry about getting the vaccine. So the intent to get the vaccine and being worried about the vaccine are not mutually exclusive. Mm-hmm. We also know that most migrant and seasonal farm workers have strong drive to work. That is why so many migrants make trips across the country, live in so-called migrant camps, often away from their families, usually away from their families and everything they know. And this drive to work and their experience with COVID over the past year may well be contributing to what we expect will be high vaccine uptake among the migrant and seasonal farm worker population. So with that, I'll finish up my own comments by bringing attention to another great piece written for the Press Citizen by one of our panelists, Martha Carver. Dr. Carver, in preparation for this evening, Dr. Carver's piece is a layered commentary about the many disruptions that this pandemic has imposed on society and the interplay with pervasive, entrenched disparities in care. So I encourage everybody to read the piece, and maybe we could put the link on chat if people can see it. Mm-hmm. I'm super excited to pass off the baton, Joan, as the panel you've created tonight, I think will really give us a rich 360-degree perspective underlying really the terrible numbers and tragic experience of so many people over the past year. Thank you so much for having me.
Oh gosh, thank you very much, Claudia. And what an eloquent description of these conditions that have made this disease a real mirror, I think, for all of us who look at the country we live in and the severe problems there are regarding health equity. Before I let you leave altogether from this part of the discussion, I thought we might discuss for just a moment the difficult circumstances the essential workers who work in meatpacking plants were in earlier this year, or last year, I guess now, when we heard in our own state and other places across the country where these workers who were doing such important work were very often, found themselves in a situation where COVID had spread quite deeply into their working group. And of course, that's not only a problem for the people in the workplace, but then you go home, you live with your family and perhaps older relatives, people in your community can get sick as well. Those folks were really in a tough situation.
Yeah. So there is, you can't even begin to unpack this in a short period of time. There are so many factors that are really so discouraging and tragic about this. There is some positive news most recently in that, for example, one of the big Tyson plants in our state vaccinated about a third of their workers so far. Mm-hmm. So that is a positive thing. Also, the fact that I believe the vaccination was occurring on site, because transportation to getting vaccines, making appointments for vaccines are really difficult. And so that is a bit of a bright light. As far as the migrant and seasonal farm workers are concerned, just today, I was on a call with several of the state agencies like Iowa Department of Public Health, Iowa Workforce Development, talking about how to get vaccines to the migrant and seasonal farm workers that are beginning to come into our state already. And, by the end of the summer, we'll have seen at least between 5,000 and 6,000 H-2A visa holders coming into the state, and that's not including the non-H-2A visa holders. So it's really a logistical puzzle to try and get the migrant and seasonal farm workers vaccinated, because they're here for a short period of time. They travel across the state. They're dispersed across the state, although there are some larger farms with more workers. So, when you talk about essential workers, there are as many stories and scenarios as there are workplaces. Mm-hmm. Mm-hmm. It's complex.
Yeah. Well, thank you so much for starting us off. Sokhieng Au, you're interim director of the Global Health Studies program here at the University of Iowa. And I wonder if you could tell us about sort of global health inequities and how these are being exacerbated by COVID-19. Again, a huge question, and I know we can't give all the answers here in just a few minutes, but let's expand a little bit beyond our own borders.
Okay, so when you're looking at the global south versus the global north, I think there's kind of in my mind, there's two big issues. There's the issue of the fact that COVID-19 and the crisis of COVID-19 is diverting a lot of resources and also the economic crisis that comes with it from the global south for other humanitarian needs. And so if you look at the knock-on impacts on other things like malnutrition, which is rising rapidly in the rest of the world, the famine that is about to erupt in Yemen, at this moment when all of these aid agencies are basically cutting funding because they don't have the money because of the global economic downturn. I think that's one of the ways that COVID is most damaging to the global south. But the other way that I really see this huge inequity, and I should also say that our COVID mitigation measures that are designed for sort of wealthy countries where we can separate 6 feet, where not all of us are in a gig economy. They don't work in a lot of the global south where you live, in extended communities. You can't have the 6 feet. Maybe you don't have clean water. You have to go out and work every day, or you don't have any kind of food, money for food or those kind of things, right? So that's already like a huge issue. Mm-hmm. The global south, these kind of measures created for us, right? That we're expecting the rest of the world to cooperate with. But the other huge way that I see this disparity between the global south and the global north right now is with the vaccine distribution and what's going on with that. Because initially the WHO had put together this very complicated process called the COVAX facility, which was supposed to, with the buy-in of like as many countries as possible in the world, equitably distribute these vaccines for COVID as they're coming into being. But what you're seeing happening is that rich companies are buying up, in advance the stock of the vaccines that are available, even beyond the needs of their population. The US, for example, looks like they're going to have excess by the summer, which is good news for us. But the problem is a lot of Africa, a lot of Latin America, a lot of South and Southeast Asia, they don't even have and they don't have the means to get vaccine for 2% of their population, for their healthcare workers, for their over 80, right? While we're vaccinating our young, healthy college kids in a few months, they don't have anything. And COVAX was supposed to solve that problem. But the problem isn't the money, in fact, because, Biden just promised $4 billion to COVAX, whereas previous administration, nothing. And people say, well, that's great, except for the fact that money gives you nothing if you don't have supply. And right now, the supply that's anticipated to come forward, most of that is being funneled to rich countries. And so it's a serious issue. And I was looking at the data this morning. The 15, let's see if I got this right, 15% of the global population has reserved 70% of the global supply of vaccine. And that 15% is the richest 15%.
Yeah.
Whereas COVAX is trying to guarantee 2 billion doses by the end of the year for sort of global population. And the richest countries have already reserved 7 billion doses for themselves. So it's a serious issue.
Yeah. You mentioned in a conversation we had before tonight's program that poorer countries that are in fact able to get some vaccines are resorting to the vaccines that have had less testing, that may be less secure because they are less expensive.
That's absolutely true. And this isn't, there are, I think from the US perspective, a lot of Americans don't realize there's more than Pfizer, Moderna, and now Johnson & Johnson, and then sort of that AstraZeneca that has been approved in Europe, but not here because of various issues with how they ran their initial clinical trials. Mm-hmm. But there are, I think, 200 vaccine candidates out there in various guises. And what you saw starting in December with certain poorer countries, they knew that even though Moderna and Pfizer had gone through phase 3 and had gone through authorization and were approved, they actually went out and bought the Gamaleya Sputnik vaccine, which was still in clinical trial phase 3 at the time. And I think they're still waiting for full approval. I think that the clinical trial was in Saudi Arabia or somewhere in the Arab region, but so that's completed. But the thing is, they haven't reached full approval yet. But you see certain countries in Latin America bought pre-purchased Gamaleya Sputnik because it's cheaper, mm-hmm. and it's not approved, and a rich country wouldn't touch it. And you see the same thing with a lot of Southeast Asian countries. They were buying Sinovac. Sinovac is a Chinese vaccine that's also not completely approved yet, but they don't really have other options, right? Because they can't afford and they can't get access to those kind of top-notch vaccines because they've been bought up by the people who have all the money. Yeah. And so they're using the less tested, perhaps less safe, we hope not less safe, vaccines.
Yeah, well, and then getting back to the more wealthy north, we still have all these reports coming in every day. The news gets worse in various countries in Europe that, went through severe shutdowns during part of the year last year, kind of opened up again. We know about Italy. We know that Germany is having trouble again. Much of the UK, they've got a pretty good vaccination rate, I guess, in the UK. But you mentioned AstraZeneca, and this is, one of the vaccines that has now been put on hold by some of the EU countries because there seems to be some concern.
There's no blood clot, but I'll tell you, I think a little bit of that is political payback because of what happened with vaccine distribution in Europe. AstraZeneca had promised to provide a certain number of doses to the EU and a certain number of doses to the UK, but their facility in the EU had production problems, so they weren't going to meet that dosage requirement at the same time as Moderna had production problems and Pfizer had production problems. So the EU was looking at this huge shortage. And they wanted some of the doses that were coming from the UK because the UK facilities were at full steam and were meeting requirements. And the UK said, no, we have a separate agreement on these facilities in the UK. They're ours, we're not sharing. Yeah. And so a little bit of that, I think, is political payback, I think.
Mm-hmm. Well, do you see this situation, where do you see things going in the next 6 months by the end of the year? What do you think we're looking at?
Well, so encouragingly, I was looking at the data. I'll tell you, three weeks ago, the only poor country that had received any vaccine was Guinea, I think, like 50 doses of Gamaleya Sputnik 3 weeks ago. Whereas we had already had millions, as well as Europe and the UK and Israel. They're off the top of the charts. But in the last week, it's been really encouraging. The AstraZeneca, not the AstraZeneca kind of under their label, but the generic AstraZeneca being produced out of India and out of South Korea. So AstraZeneca has a generic licensing that was part of in their development that they kind of built in at the very beginning. So the generic versions of the AstraZeneca are being produced in these much cheaper facilities at a much lower cost, and that's what the COVAX facility is using. But in the last week, you're seeing hundreds of thousands of doses starting to go out. So in the first quarter of this year, they want to get 2% of the population maybe vaccinated in all of the COVAX participating countries, they hope. So it's getting better, but they're still, I mean, the WHO is not happy with the kind of queue jumping that the rich countries have done despite their kind of lip service to commitment to solidarity.
Yeah. Wow. Well, thank you for that sobering news. But as you say, maybe a little glimmer of hope there at the end.
Yeah.
Ashlesha, let's go to you and talk about kids. You're a pediatric infectious disease specialist. Tell us a little bit about what you see in your community or when you're working in Iowa. How do socioeconomic disparities impact children and adolescents in COVID or in other circumstances?
Yeah, thank you, Joanne. And it's great to be here. It's an honor to be a part of this very timely discussion addressing socioeconomic determinants of health in context of COVID-19. As we have all seen, the COVID-19 pandemic has been unprecedented in so many ways, including exacerbating socioeconomic disparities, as we had an extensive discussion till now, and also the impact on children and adolescents. Studies have shown that the risk of exposure to COVID-19 because of the living conditions, as well as the prevalence and severity of COVID-19 disease, have been much higher in children in these disadvantaged populations, not only in the United States, but across the world. Crowded living conditions and unstable housing, they contribute to transmission of COVID-19 and can hinder prevention strategies like hygiene measures, self-isolation, self-quarantine. Additionally, more people of racial and ethnic minorities are employed in occupational settings, like was mentioned in meat packaging industry, for instance. And we locally saw a surge in Siouxland area as well, in those kids presenting to us. So it's just not, the socioeconomic background, but also, where they work, they bring the things home also. So, the living conditions are bad and the working conditions are not good either. So if we talk about hospitalizations due to COVID-19, all the literature evidence supports the fact that majority of the patients hospitalized with COVID-19 have been people of color. So the CDC estimates that among all patients hospitalized with COVID, and this is scary data, like, last year, all the patients hospitalized with COVID in United States, the majority, that is 44% for Blacks, followed by 36% Hispanic or Latinos, and 16% for white patients. This is aggregate data from the CDC, as checked last night. Moreover, underlying medical conditions, they play a huge role in this. A higher incidence of diabetes, high blood pressures, higher body mass indices. All these are risk factors that place these racial minorities at higher risk of developing greater illness severity and dying from COVID than other racial groups. Another shocking, rather surprising, but it's sad piece of data, also a study of selected states and cities with data on COVID-19 deaths by race and ethnicity, recently published on the CDC website, shows that 34% of deaths were among non-Hispanic Black people, although this group accounts only for about 12% of the total US population. When we talk about people aged less than 25 years of age, a recent CDC study showed that racial and ethnic disparities in COVID-19 incidence amongst persons in this age group in 16 US jurisdictions were substantial during last year. Among minority groups like Native Hawaiian and Pacific Islanders, American Indians and Alaskan Natives, along with Hispanics and Blacks. So we tend to forget these groups, but these were also, some of these groups had the highest relative increase in COVID-19 over last year when we look from January to December data. In terms of severity of disease, multi-system inflammatory syndrome in children, commonly called MIS-C, is a rare but a very severe condition that occurs approximately 2 to 4 weeks after occurrence or after COVID-19 exposure in children and adolescents. Majority of children with multi-system inflammatory syndrome need intensive care and they can get very, very sick. several pooled analyses, CDC data, a recent study in JAMA, and one of my published systematic reviews in Pediatric Infectious Disease Journal, we have all shown that multi-system inflammatory syndrome disproportionately affects children and adolescents from racial and ethnic minority groups. So in all this rhetoric so far, I've mentioned like the severe disease, going on ventilators, as well as suffering from multi-system inflammatory syndrome. All of these have mirrored, the children and adolescents have kind of mirrored the adult population coming from racial and ethnic minorities. You know, the adults in these populations have gotten admitted more, and so are the children, you know. So it's not surprising, and it's surprising in a way, you know, it's just very sad. Another recent study showed that 60% of patients, like children, aged 6 to 12 years with this syndrome, needed intensive care admission. And to no surprise, ICU admission was also more likely in the non-Hispanic Black patients. So not only are these marginalized populations facing risks of greater acquisition of COVID-19 infection, but also bearing the brunt of severe disease, as we discussed, right? In addition, there are other tangential health consequences of the pandemic that are far-reaching, and that we must not forget in terms of mental health challenges, physical health issues, and also dropping numbers in immunization overall for, you know, other serious vaccine preventable diseases which are predisposing these populations to those serious monsters. So I would like to draw attention to that too. Like, you know, the COVID-19 pandemic has not just affected these in terms of disease, but also had laid bare many inequities and exacerbated the vast differences in health outcomes tied to race, ethnicity, and incomes. So the lack of equity in resources means less green spaces for most poor families living in crowded conditions with no backyards, no babysitters or nannies, for most part, because they can't afford them. During the pandemic, it just meant that most of these kids were stuck at home with greater screen exposure, more screen times, resulting in additional dimension of physical problems like increasing overweight and increasing obesity, and, you know, with their own bag of troubles, including high blood pressures and diabetes in the long run, and also mental health issues like increased aggressive behavior, attention deficit issues, anxiety and depression, suicidal ideation. In fact, you know, American Academy of Pediatrics has labeled this a total era of mental health crises for childhood and adolescent patients. So they are saying that these mental health crises that we are seeing are some of the most devastating effects this pandemic has had on marginalized pediatric populations. So I guess, you know, there's no question that vulnerable populations are the worst affected. And because they are the worst affected, that leads us to the second part of the conversation, which probably the other experts will lead us into, is that, you know, efforts to ensure adequate vaccine acceptance in these populations should be a priority for the scientific community. So I would say all these reasons that I mentioned are compelling reasons that underline the urgent need for COVID-19 vaccine acceptance for children once it gets approved for these marginalized populations, once we have like safe and effective vaccines. In conclusion, I'll just say that establishing healthcare equity should be a priority, and ensuring equitable and timely access to preventive measures and vaccination when eligible is important to address these youth, racial, and ethnic disparities and gaps. Thank you.
Well, you've all really made that last pitch very strongly, that this is what we're dealing with right now, but it's really exposed a terrible kind of inequity and unfairness in our system. Do you think there's the political will? I just ask anybody to answer this. Do you believe that having gone through all of this, and even those people who are only a little bit tuned into what's happening nationally are becoming more aware of what different groups of Americans are suffering, just looking at our own country now, do you feel that there is national will to try to address some of these inequities that only exacerbate problems when you have something like COVID?
I mean, I can speak a little bit about, what was I going to say? I totally went blank. I think there's a huge discussion. There's a huge discussion in global health, and I think it's also in the public health, American public health field, where this is an opportunity. Like, it's very clear that COVID-19 has revealed the social determinants of health. We've been talking about it for ages, but COVID-19 has absolutely exacerbated everything along the lines of sort of vulnerable populations, and it's just a lot harder to ignore. But then you see a lot of conversation right now about this is a moment. This is a moment when we can reform the healthcare system. This is a moment where we can reform global health to look at these social determinants and structural determinants and really attack them, you know, from the ground up. This is a moment that we can rearrange everything. Is it going to go anywhere? I don't know, but there's a lot of talk about this being an an opportunity because of the crisis.
Yeah. Well, as we wrap up this segment, I'd like to share a question that came in from a global health student here at the University of Iowa. And she had two questions. You have all just answered the first one, but the second one was, how can students who are interested in improving care for marginalized and vulnerable populations get involved in the field? What can the students you're all working with today do?
They can actually, I have a suggestion of joining a coalition, statewide coalition, Iowa Immunizes. We are very, very active in terms of promoting vaccination efforts at all levels in the state. And, we have the partnering organizations include the American Academy of Pediatrics and lots of, I think more than 20 organizations across the state, including nurse practitioners. University of Iowa is also probably one of the organizations that is a collaborating member. And Blank's Children is, UnityPoint Health is, so several large health organizations. I think it's a great way. It's not like it's voluntary, and they have monthly meetings, and maybe Joanne can connect those students to Elizabeth, who's the coordinator. Maybe that's one of the avenues in which they can, they really give their services, and we really appreciate more voices there.
Yeah, thank you. So the group was Iowa Immunizes, and we will share that information, absolutely. Claudia or Sokhieng, anything else to say before we wrap up this segment?
So I think one thing to say to the young people who are asking the questions is that, public health has always been the poor sister of healthcare. And for forever, medical schools had the big fancy buildings and the public health schools didn't. But I think secondary sort of, I don't know if you could put it this way, but benefit of the pandemic, although that sounds a bit deaf to say it that way, but just the same, is that the field of public health is been elevated, and people are understanding that it's far-reaching. It involves so many different things, and that as you go through your studies and whatever area you're interested in, you could always pair it with some studies in public health. And public health will complement almost any other field of study. So that's one way to approach it. And the other thing I say is be bold. If you're interested in someone, look them up, call someone up, be bold, advocate for yourself, make a phone call, say you want to work with them. This is who you are, and don't be shy.
I would second Claudia, well put.
Yeah, nice thoughts. Thank you.
Great. Well, gosh, thank you all for being with us for this first part of the discussion. Claudia Corwin, thank you. Sokhieng Au and Ashlesha Kaushik, thank you all very, very much. And I hope all of you watching will please stay with us for the next segment of WorldCanvass, when we'll speak more specifically about vulnerable populations here in the United States. So we'll be back in just a moment.
Thank you.
Mm-hmm. Welcome back to WorldCanvass and our discussion of COVID care for marginalized and vulnerable populations. I'm Joan Kerr for University of Iowa International Programs. In this part of the program, we want to focus more directly on groups within the U.S. that have increased vulnerability to diseases like COVID-19 and less access to high-quality health care. My guests are Martha Carver, Assistant Professor in the Department of Internal Medicine in the Carver College of Medicine, and Assistant Professor in the Department of Epidemiology in the College of Public Health here at the University of Iowa. Thank you, Martha, for being with us. And yes, and Denise Martinez is Associate Dean and Clinical Associate Professor in the Department of Family Medicine in the Carver College of Medicine at the University of Iowa. Thank you for being here, Denise.
Thank you.
Mm-hmm. Kevin Washburn is the Dean of the University of Iowa College of Law. He is also a member of the Chickasaw Nation of Oklahoma. Welcome, Dean Washburn.
Thank you for having me.
Mm-hmm. And Jackie Easley McGee is the Director of Community and Diversity Services at Mercy Medical Center in Des Moines. Thank you so much, Jackie, for taking the time to join us.
Thank you, and I'm proud to be here on this panel.
Thank you. Well, I'll start with you, Martha. When we look at our state specifically, what do we see as the impact of COVID on different racial or ethnic groups?
Yes, well, thank you, Joan, for putting together such an incredible session tonight. I learned a lot from the panelists already, and some of what I will say will pick up on some of those themes too. So in Iowa and around the US and really around the world, we've seen very consistent disparities for really every historically minoritized racial or ethnic group. The ways in which this has played out in terms of the course of the pandemic, or some of the specific types of disparities may differ, but we've seen this very consistently. And this is the result, threading back with some of the comments from the first session. This is the result of longstanding structural disparities for a number of patient groups and patient populations. We've seen that here in Iowa, we've seen that throughout the United States. I think what is important to recognize when we think about the idea of vulnerable populations is also what vulnerable means and how we talk about these types of terms and expressions. And so when we're talking about health disparities, or we're talking about vulnerable and marginalized populations, it's really important to place the onus of that, of the issue or the concern or the problem on the system that has perpetuated that. So these are vulnerabilities or marginalization or marginalizing effects that are the result of a system. And that's important because when we have a systematic or a structural problem, it requires a systematic and a structural solution. So when we talk about this in terms of disparities for patients in Iowa or around the US or around the world, it's also important to highlight, and again, this will tie back with some of what was discussed in the last session, that we're talking about disparities or inequities that have played out in COVID, but also in other impacts of the pandemic. So we talk about the infection and mortality rates related to COVID specifically, but also impacts related to the socioeconomics around the pandemic. So things like job loss or housing loss or food insecurity or employment or educational opportunities that have been largely disrupted during the pandemic. And we've seen many of those disruptions throughout society. There are also disparate effects of each of those things across a number of historically minoritized or marginalized groups. That's important because each of those things plays into or becomes a part of the social determinant of health, and therefore can lead to adverse disparities down the road as well, or adverse health outcomes. And that's actually the final thing that I'd like to particularly highlight in terms of the domains of the impact or the disparities that we observe. One of the things that I'm perhaps most worried about is the disparities that will get worse in other non-COVID health conditions. So we know that there are longstanding disparities in other types of infections, including vaccine preventable conditions, which I know was mentioned in the last session, in cardiovascular disease and diabetes, in maternal health, in a variety of other health domains. And with the disruptions and interruptions in care that we've seen in COVID, those will have disparate effects as well. And those disparities in other health outcomes are things that we will continue to see in the years and the decades ahead. So it's critically important that we think about structural solutions that we can implement now, and the messaging around that really causes us to engage directly with communities and patients and ensure that we're offering equitable systems and equitable care. I think one of the things that is most important for me in terms of how we think ahead, how do we actually get this done? How do we think about solutions? How do we build a system that is safe for everyone to travel and safe for everyone in which to seek healthcare? Part of that requires us to do a lot of reflection and then a lot of change in the way that we work, or the way that we think, and even the way that we talk. And we can start in the way that we talk about the pandemic. So we have talked very proactively, very actively about masks and vaccines, and that's important. It's critically important. Masks and vaccines can save lives. They will save lives. They're already saving lives. We need to talk with that same sense of urgency and criticality about health disparities and health equity, because health equity is also urgent, it's also critical, and it's also something that if we enact it now and we use this critical opportunity and this momentum, instead of treating it as something that is just something to be noted or documented, but something that really needs to be acted on, we also have the same potential to save lives and prevent a lot of suffering. Thank you.
Yeah. Oh, thank you. Thank you so much. And also your piece for the Iowa City Press Citizen was mentioned in the first segment. And for those who haven't had a chance to read it yet, it's really terrific. And it could be found on the International Programs website if you'd like to read it. It's a piece by Martha Carver. So thank you for starting us off, Martha. And I would like to go to you next, Denise, if you don't mind. So you are Associate Dean and a Clinical Associate Professor in the Department of Family Medicine here in the Carver College of Medicine at the UI. you come into contact in that clinical setting with people from all over Iowa, people from many different backgrounds, and in some cases, those people do not have English as their first language. And as COVID began to explode, and please tell me if this was also happening before COVID became a reality for us, but obviously there are many people who come to the UIHC who are most comfortable in Spanish. I know you're part of a group of physicians and medical workers who have tried to help some of the family members who have patients in the hospital and have a lot of questions. And you've tried to sort of help them understand what fears might be reasonable to have and help them break down barriers to care. Can you tell us a little bit about that effort?
Yeah, so thank you again for having me. And, I too have learned a lot. This is a really wonderful group of folks who have a lot of really excellent knowledge. And I very much agree with what Dr. Carver said as well. What she said was very true and very excellent. We know that language barriers can be really, really challenging. And obviously, I can remember it's been about a year, and it was actually a very scary time. We didn't know very much about COVID at that time. And in our family medicine clinic, we quickly had to transition to figuring out how do we get people tested quickly? How do we people get access to get tested quickly, especially because we had limited tests right at the beginning of this pandemic. How do we help folks sort of navigate the system? And then the folks, especially who have been hit really, really hard, as many have already shared within this program, have been folks of the Latinx community, particularly in Iowa, as who is considered essential was very obvious from the meatpacking industry to other industries that have high percentages of Latinx folks who are participating in those industries. And we knew very quickly that we had to figure out how to provide language services, how to help people navigate how to get an appointment for a telehealth visit and what does that look like. And, all of these things can be extremely complicated. And when you have, a large family with lots of folks with high-speed internet and significant amounts of English proficiency, it can be, not as hard to navigate that. But if any of those things are missing, it can be extremely difficult to navigate that. So working in those spaces to try to make, interpreters have access to interpreters, especially in the influenza-like clinics, as well as on the telemedicine platforms. The other piece that was really, really important, and something that I was not involved in, was we have quite a few people who are in our pulmonary and critical care teams who work in the ICU and who are physicians and providers who are Spanish speakers. And, especially at the beginning and even till now, you can have limited numbers of folks who are able to go and visit. And so here are folks who are absolutely critically ill and who are intubated and are scared and sick and et cetera. And it's a very disorienting type of environment. And the family wants to know what's going on. The patient wants to know what's going on. And so having folks who can provide that culturally responsive care and take shifts to, call families and speak to patients and do it in a way that is in people's most comfortable language, that is critically important and something that I'm proud and glad that we did. We also did a home hospitalist program, which I again, calling patients at home in Spanish and in other languages to help take care of them at home and give them access to be able to check vital signs and that sort of thing. So there was work that has been done, but I think, as Dr. Carver mentioned, there is so much more work to be done to how do we, address systemic inequities in our healthcare system and do better, especially going forward.
Yeah. Wow. Well, thank you for sharing that with us. And now I'd like to move on to Kevin Washburn. I mentioned he's the Dean of the College of Law, also a member of the Chickasaw Nation. Kevin, thank you so much for joining us. And I think many of us had a hint of this, but you shared some statistics with me before the program that are some of the saddest statistics for COVID, deaths and other health issues and other things as well that are found within the Native American population. And your own background it gives you a perspective into the socioeconomic realities of Native American life. how does the health and well-being of Native Americans compare to that of other groups in the country at this moment in time?
Well, it's interesting. There's some similarities and some differences. And Dr. Carver did a nice job of explaining that these are systems and structures that we've set up that create all this. And it's so true. And we've got a lot of inequities just built in. And Dr. Martinez talked about some of the issues with language barriers for the Latinx community. It's interesting. So we've got a different issue in the Native community, but it is related to language. So in the Native community, we not only have human beings dying from COVID, we have languages dying because it's in many cases the elders that retain the native languages the best. And if those people die, the language goes with them in many respects. And so that it's just a different level. It's, similar disparities, but different ways that it impacts our communities. Across a range of social indicators, Native Americans face a really difficult world. And some of those things are obvious to people, but some of them are not so obvious. So when we think of police violence and deaths at the hands of police, we think of George Floyd, we think of Breonna Taylor, and we think of, frankly, dozens of other names that we've heard over the last several years of African Americans, Blacks who've been killed by police. The CDC has studied this issue, and because it's a public health issue, and between 1999 and 2015, Black Americans were killed by law enforcement at a rate of 2.6 people per million people. So 2.6 per million. During the same period, Native Americans were killed at the rate of 2.9 per million. So Native Americans, even though we think of this as a Black issue, it's actually worse for Native Americans. And there's a whole lot of issues, social indicators that are worse for Native Americans than for any other group, including injury-related deaths, suicides by men, suicides by women. Overall mortality rates are really bad. And COVID early on, the first 6 months or so, 9 months of the COVID epidemic, the hospitalization rates were, higher for Native Americans than for any other racial group. And it just shows that, racial equity has been a significant issue. It's an issue differently for Hispanics and Latinx people and Black Americans and Native Americans. It impacts all of them very seriously, though. And there is some good news to report. The Biden administration has taken a real significant approach to racial equity, and it's not equality, it's equity. It's because you can't treat people equally and expect equities to be addressed. So from the very start, the Biden administration has taken a bunch of steps for Native Americans. I'm not sure what they've done in the other communities because I'm not focused on those as much. I'm not as knowledgeable. But in the Native American community, they've done several steps. One of them was on his first day, President Biden opened up the FEMA disaster relief funds to tribes with a 100% cost share. So the tribes used to have to bring 20% of the fund. If they had a $10 million disaster, needed $10 million of relief, they would have to bring the first 2 million and then the federal government would bring the other 8. And that was a 20% cost share. It's now a 100% federal cost share. So Native American tribes are getting more support for these things. Another significant improvement was that the Biden administration opened the National Strategic Stockpile of medical supplies to Native American tribes. And there's also been just a significant focus on the Indian Health Service, which serves tribes and reservation-based Native Americans, and on urban Indian communities. And so they've been working to push vaccines out. And I will tell you, it seems to be making a difference. 6 weeks ago, the only people I knew that were getting vaccinated were healthcare workers and Native Americans, because the Indian Health Service was making a specific effort to try to help Native Americans because they are feeling the impact of COVID-19 so much more strongly. So that's what equity means. It doesn't mean giving things to everyone equally. It means focusing on the communities that are hardest hit and making sure you're taking care of those. And we're seeing some evidence of that in the Biden administration.
Mm-hmm. Well, Kevin, I understand that you spent a large amount of your time growing up. I don't know if it was all of the time when you were growing up, but you lived on the reservation. And I think for a lot of us, it's a very sort of, we have an opaque view of what it's like to live on a reservation. And what can you tell us about the kind of healthcare, the kind of schooling you were exposed to when you were a young man?
Well, I grew up in the Indian Health Service system. That's where I got my healthcare growing up, and you know, I'm lucky to have had it. It was something that everybody complained about all the time, and it was given back then by the Indian Health Service, by the federal government. When I went off to college, I guess to law school, the tribe actually ended up taking over that system, and the tribe took the resources that the IHS had, the money, and hired its own healthcare workers and started taking over that process itself. And actually the care improved, and the quality and the customer service improved when the tribe took that function over. So it improved when the tribe actually started exercising its right to self-govern and to use the federal resources to serve itself. And the reason for that, you might imagine, it's not easy to a federal employee is not going to get terminated because they just inconvenienced an Indian family, but a tribal leader might get unelected in the next election if he inconvenienced or she inconvenienced an Indian family because she loses votes. So it's made the whole system much more accountable to Native Americans. So it has improved. The healthcare system has improved in part by the greater involvement by Indian tribes in taking care of their own people. So there have been some improvements since I was a kid.
Yeah. So we have the other panelists joining you on this part of the discussion and the prior one as well. People have been talking about these structural changes that need to be within the relationship of tribal leadership and U.S. federal leadership. What kinds of snags are there that happen there that perhaps should be addressed in order to improve life for Native Americans?
Well, I don't know. You have to be on Facebook probably to notice this, or have to have friends in a lot of different states. But you can see that the quality of the way that all of this stuff is rolling out is different in each of the states, and how quickly, what the priorities states are making about distribution of vaccines is different from one state to the next. And you see a little bit of that in Indian country as well, because there are 574 recognized tribes in the United States, and each of them theoretically has the power to do things a little bit differently. Now, they've all taken this risk very seriously, again, in part because the loss of native languages and seeing elders pass away. And in tribal communities, elders are elevated, and you know, losing elders is a serious problem. And so they've taken it very seriously, I think. But there are differences from one tribe to the next, just like there are differences from one state to the next. And so that's one of the little snags, I suppose, is that, you know, you got too many decision makers, arguably.
Yeah. Yeah, well, gosh, thank you. And so let's turn to Jackie Easley McGee. You are the Director, Community and Diversity Services for Mercy Medical Center in Des Moines. Jackie, real pleasure to have you with us. And I wonder now if we could have a little reflection from you on what COVID has done to the Black community across our state, obviously with the caveat at the beginning that there is not just one community with everybody living in the same social circumstances and so on, but at large, how has the Black community fared during COVID, those living here in Iowa?
Well, thank you, Joan. And as I stated in the beginning, I really am delighted to be participating tonight because part of my work, most of my professional day work is involved in health equity. And thank you, everyone, for providing explanation of the difference between equality and equity. I do work with every single unit in our health system and work ways to achieve and to eliminate the gaps, mainly through outreach, through many nonprofit organizations. But I have been a lifelong member of the NAACP, and currently I serve as the Iowa-Nebraska Health Chair for the NAACP Conference of Branches. So just a little background for people who may not know who the NAACP is. In 1909, the call forged a consensus among willing Americans of all identities that was necessary to form a national organization that would advance the interests of people of color through coordinated action and reasoned argument. And more than a century later now, the NAACP, through litigation and probably the most famous of the NAACP efforts were certainly Brown versus Board of Education in 1954 with soon to be Supreme Court Justice Thurgood Marshall. And then as we head into the 60s and beyond, we now are seeing, the litigated efforts in many of these police cases that Kevin Washburn has described. And certainly we are very, very involved in police, anti-racial profiling police efforts, and scored a victory here in the state of Iowa within the last year with the legislature voting 100% as a whole to support, those efforts in recognizing racial profiling. And so the NAACP, in summary, considers itself the largest and the oldest, the baddest and the boldest, the most loved, the most hated, the most feared, the most revered, the most cussed, and the most discussed civil rights organization in the United States. And as they turn their focus then in 2021, have identified some strategic initiatives that they call game changers. And using that definition of vulnerable that Dr. Carver started our discussion with, I think applies to these areas. The first game changer was economic sustainability. And if you look at the number of homeowners in the African-American community, the least likely to have bank accounts, least likely to be able to receive a loan, you will see why economic sustainability has become one of the game changers for our organization. And then, of course, there's education. And I mentioned that historically, much of the NAACP's legal work has centered on distressed and inequitable school systems, originally through desegregation efforts, but now looking more and more at equity in terms of teacher to student ratio, and so forth. Public safety and criminal justice is a game changer. And again, I've highlighted that certainly as we are looking at racial profiling issues, even in our own state here in Iowa, that's very important and significant in eliminating barriers and equitable dispensation of justice for all. Voting rights and political representation is a game changer. Now more than ever this year, we have seen obstacles now to some of the gains that have been made in the past. Protecting and enhancing voting rights and fair representation has always been and will continue to be one of the game changers for the NAACP. Expanding youth and young adult engagement. Many people aren't aware that we have youth councils, and these are individuals. It's a chapter at Iowa City. These are individuals who are engaged at earlier levels and younger levels in this work. And so then finally, there's my area, which is health equity for all. And in 2021, I would like to think that we have been at the forefront of, many people have stated earlier in our conversation how important this opportunity is. The pandemic, in my opinion, has ripped the Band-Aid off long festering wounds of inequities and historical trauma related to health measure outcomes in all people of color. And so now more than ever, as many people have stated, I call this the time to seize the moment and be able to use this as an opportunity where we can not only understand what vulnerable populations mean in this state, in this country, but healthcare truly as a public, or racism as a public health crisis. So the NAACP, in answer to your question, is significantly focused on the COVID statistics that have revealed certainly disparities that we long have known have been there. Even here in the state of Iowa, where African Americans represent about almost 4% of the population. Early on, the number of African Americans Black Iowans who were inflicted with the virus we're almost double the population of our state. And certainly that was also reflected in other populations as well. And then now, as we look at the numbers who are being vaccinated, it is disconcerting that only 1% of African Americans nationally, and we see that same statistic here in Iowa, have been vaccinated. There are groups and organizations, such as my own church, that is hosting a mass vaccination clinic in a couple of weeks to really reach out and address those disturbing statistics.
Mm-hmm. Well, one hears that more persuasive than a government leader saying, hey, you really ought to get this vaccine, or someone from the CDC saying, absolutely get the vaccine. It matters when community leaders, people who are known in the community, whatever, perhaps a Latinx community, perhaps the Black community, when people who have worked with those populations before can step right up and say, you know, I've taken the vaccine. You have to sort of say, trust me on this. This is going to be better for you than not taking the vaccine. Is this one of the things you certainly mentioned that your church is having this vaccination drive here in short order? Are you finding that there are community members in the Des Moines area who are stepping out like that to get personally involved?
Yes, and not just Des Moines. And trust is a key factor. The NAACP did a poll, I would say early summer to late summer, and found that trusted messengers, individual leaders in the faith community, leaders of nonprofits that people were able to, see and talk to, and personal testimonies. About a week ago, I conducted a panel, I coordinated a panel for I'll Make Me a World in Iowa, which is our African American festival, kicks off African American Heritage Month here in Iowa. And on our panel, in addition to having public health leaders from a couple of counties in Iowa, we had an individual who participated in the clinical trials early on, I believe at University of Iowa. And he really gave powerful testimony. He's an individual that is known here in Des Moines. He works at Drake University, and shared his story of why he wanted to participate in the trials. He did it for his family. His family had multiple concerns, as do a lot of our families. And he felt that if he were to participate, share his experience with the side effects, and live to tell about it, so to speak, that he would be able to really influence and make a difference. And he has, I believe, in terms of making a difference in our community by sharing that experience.
Wow, that's terrific. That's great. I will just ask the group before we wrap up this segment, is there anything anyone would like to add? This has been such an informative and inspiring conversation. I so appreciate it. And so I guess we'll just say thank you to all of you. Our guests have been Martha Carver, Denise Martinez, Kevin Washburn, and Jackie Easley McGee. You'll be seeing Jackie in the next segment as well. So I hope to all of you viewing the program, please stay with us for the final segment of WorldCanvass. And in that segment, we'll be talking specifically about the issue of vaccine hesitancy. I'm Joan Kerr for International Programs, and we'll be back in a moment. Thanks, everyone. Hello again, and thank you for joining us for this WorldCanvass program on COVID care for marginalized and vulnerable populations. I'm Joan Kerr for UI International Programs. I am pleased to introduce our guests for this segment where we'll be talking about vaccine hesitancy. Kimberly Dukes is with us. She is a research assistant professor in the Department of Internal Medicine at the University of Iowa Hospitals and Clinics. Thank you for joining us, Kimberly. Erin Scherer is assistant professor in the Department of Internal Medicine in the Carver College of Medicine here at the University of Iowa. Hi, Erin. Thanks for being with us.
Thank you.
Mm-hmm. And you've already met Jackie Easley McGee, the Director of Community and Diversity Services at Mercy Medical Center in Des Moines. Thank you, Jackie. And Claudia Corwin has been with us in the earlier part of the program. She's the Director of the Iowa Global Heath Network, also an occupational medicine specialist and a clinical assistant professor in the Department of Internal Medicine at the UI Hospitals and Clinics. So welcome and thank you, all of you. Kimberly and Erin, I'd like to turn to you two first. Aaron, let me go to you. Why would anyone hesitate to take a vaccine that's been tested and approved by the FDA?
Well, it's there's a number of reasons, and as a social psychologist, I'm primarily interested in identifying and using psychological processes that contribute to vaccine hesitancy to really try to promote it in these groups. And so I think that there's kind of two reasons why people might be hesitant to get a vaccine that's approved by the FDA. One factor, which I'll call an information gap factor, is when people might be vaccine hesitant because they're missing some key pieces of information about the infectious disease or the safety and efficacy of the vaccines. And so, this is a factor that's focused on by most theories of health behavior. So an example of this would be, the pervasive belief, concern about how quickly the vaccines are developed. So, we haven't done a very good job about communicating that as public health experts. And so I think that that's one of the things that, if we provide that information to some people, that might help shift them in a more positive way. The other contributor, which hasn't received very much attention in the vaccine hesitancy literature, is a psychological concept known as motivated reasoning. And motivated reasonings are just our tendency to, attend to information and process information in a way that's consistent with things we already believe. So in the context of the COVID-19 vaccines, there's been two kind of main ways that this has been manifest. There's, obvious ways, such as the rapid changes that have occurred in terms of vaccination intentions for Democrats and Republicans. It's basically been, they were apart and then they converged, and now they're diverging again, as well as, mistrust of the healthcare system by marginalized communities. But there's also more subtle ways that people can engage in motivated reasoning that might undermine their confidence in vaccines. And based on psychological traits that they might have. So we know that people, the extent to which they vary in how much they value moral and physical purity is associated with vaccine attitudes, as well as how uncomfortable they are with uncertainty, and they have how much they have a need to reduce uncertainty. So I think with those two contributors in mind, there's kind of three recommendations I have to make when communicating with groups who might be a little more hesitant. The first is, meet people where they're at, not where you want them to be. I think one of the sins of public health messaging that we constantly engage in is that we select information that we think is important to communicate. And then that's what we send out. Instead of this, I think we really need to identify the information needs of a community. And this has been brought up before about using language that a community is familiar with and comfortable with and resonates with. So for example, the way we've tried to deal with allaying concerns about the speed of COVID vaccine development and availability is by saying all these vaccines have gone through all the safety protocols of the FDA. But that really doesn't address, how or why the vaccines were able to be developed so quickly without sacrificing safety. And secondly, if you're already skeptical of government organizations or the FDA, saying that it's FDA approved isn't going to increase your confidence in the vaccine. So it's kind of counterproductive. Mm-hmm. A second thing is, we know that providing information that kind of fills in these information gaps or corrects misperceptions, they might work for people who are generally positive or maybe even neutral towards vaccines. But however, there's studies showing that when you give corrective information to people who have negative vaccine attitudes, you can correctly kind of address the misconception and change the misconception so you can correct their belief, but actually decreases their vaccination intentions, which is actually the outcome we care about. So you get this backfire effect. And so as a result of that, my second recommendation is more theory-based, and that's redirecting these motivations that contribute to vaccine hesitancy in a way that might promote vaccination. So as an example, you can think about needle phobias. So a lot of people don't get vaccinated because they're afraid of needles. One approach you could take could be to draw attention away from the fact that you get, a jab with the vaccine and highlight the number of needle sticks you might get if you're hospitalized with an infectious disease. So you're trying to take that, kind of motivation and then turn it around to promote the vaccine. And then finally, just, this was brought up at the last session, nothing is going to work if you can't build trust with these communities. There's a quote attributed to President Theodore Roosevelt that nobody cares how much you know until they know how much you care. And I think that's, critical, especially when trying to work with, marginalized and vulnerable communities. Unfortunately, this means we should have been working with these communities well before the pandemic started. But I think given where we're at now, it's a matter of identifying trusted individuals within those communities. Jackie just was talking about this earlier. Identify trusted individuals who can serve as advocates for COVID vaccination. And we know that, data doesn't move people, stories move people. And so getting people from those communities to tell their stories about how they move from, being skeptical of the vaccine to wanting to get the vaccine, or their experiences with the COVID vaccine are going to be more successful at improving vaccine uptake in those groups than just throwing data and information at them.
Mm-hmm. No, that makes sense. Do we know whether the vaccine hesitancy that we're learning about regarding the COVID vaccine is greater or about the same as other kinds of vaccine hesitancy? Is there any data on that yet, or is it too early to know? If any,
there's been lots of data collected. I think it's hard to kind of directly compare, but I think that there is increased concern because it's important to note that vaccine hesitant doesn't mean that you refuse all vaccines, but it's on a continuum. So you can have people who, are get all their vaccines, but still have major concerns about it. And I'll say, at the beginning of the pandemic and when we were talking about vaccines, I was concerned about the speed that the vaccines were being developed and being made available. And it took months before I heard someone provide an explanation about how, these vaccines are based on, vaccine development from SARS-CoV-1 from the 2003 outbreak. So they had a foundation already in place. So they were able to move quickly on that. And other reasons. But so I think there is increased hesitancy because we've done such a bad job communicating like critical information and concepts to people.
Mm-hmm. Yeah. Well, thank you, Aaron. I'm going to jump over to Kimberly now. Kimberly, your PhD is in anthropology and you're a research assistant professor in internal medicine. How do those fields mesh together?
That's an interesting question. I think in many ways, actually, I think medical school follows a lot of the same training that anthropologists use when they're trying to learn about a community. So you are doing field work in a way, right? You're talking to people, you're in their daily life, you're asking questions, you're looking for patterns, you're paying attention to individual practice, and you're doing it kind of hands-on while you're doing it. So I think there are a lot of overlaps. But I think in general, I am glad that our Carver College of Medicine has been really historically open to medical anthropologists and sociologists and values that perspective of actually talking to patients or healthcare workers and understanding what their lives are like and kind of how that knowledge can inform better healthcare, hopefully.
Yeah. Well, so we just heard from Aaron and from others in the program as well that communication is really so key to not only helping people who have someone suffering in the hospital with a COVID infection, but also helping all of us sort of understand what the vaccine can do. And is it also your feeling that communication is kind of the biggest hurdle?
I think it's again a super complicated question, as you've been asking folks all night. I would agree with Aaron that sometimes approaching things from we're just communicating the information we think you need is not going to work, and in fact can increase vaccine hesitancy. So I guess how I would kind of hedge that conversation would be that communication can't be one way, and it should be developed in collaboration with a wide number of communities to ask and to listen what their concerns actually are, and take those concerns seriously, not to treat somebody who is vaccine hesitant as somebody who is ignorant or defiant in some way, to actually treat them as intelligent people with good questions, and perhaps reasonable fears and reasonable distrust. And to have them, for example, if we think about COVID, from an anthropological perspective, I think it probably would work better for any communication strategy to be developed in partnership with communities after listening to them about fears and concerns, and giving them a real voice and power in making decisions about the allocation of vaccines, how that should actually roll out, and making sure that their concerns are built in an equitable way through the whole process. And we should have been doing this long before, but certainly we should have probably started having those conversations seriously as they were thinking about, we're trying to make a vaccine. And so it really is too bad that we have kind of waited in many ways to think about it now.
Well, and it was such a confusing year last year because we had so many political motivations on various sides that were splintering Americans into different groups, and people follow the science or listen to the president. There were different messages coming from different sources, and that I think created a lot of confusion for lots of people, and some of that probably still remains. Let me turn back to Jackie here for a second. You mentioned that the numbers of Black Americans who indicate that they will be vaccinated still seems to be very low. I thought that I had heard earlier in the week that there appeared to be a little bit more acceptance to the idea of getting the vaccine among the Black community. Did I mishear that?
No, and the number I was quoting is the number who have actually been vaccinated. So I think there are many factors. One is certainly we have the tiers. And, as we advance through the tiers with populations and so forth, hopefully we'll see that number increase. However, we still have the concern about hesitancy. The Pew Research Center in November conducted a poll, and about 58% African Americans said that they planned to decline to take the vaccine. And of course, we have already highlighted some of the hesitancy factors. Historical trauma is an issue that comes up a lot that I hear, maybe more generational. I imagine that you all are familiar with the Tuskegee so-called experiment, Henrietta Lacks, and the many, many examples of African Americans being used as medical guinea pigs. And that then has affected a certain generation, I believe, of African Americans. There are many other reasons besides those historical factors. But what I think has really been, if we can point to some things that have been positive during this period, is when that poll came out, many organizations came together, the NAACP, social organizations, sororities, fraternities, faith groups, and said, we cannot let that happen. We cannot allow more than half of our population not feel comfortable taking the vaccine. So as I mentioned earlier, many of us have been involved in panels that we have put together. We've had trusted messengers discuss the efficacy of the vaccine. I mentioned personal testimony from individuals who participated in trials. I think in addressing Aaron's very valid issue that he raised about many people's concern about the vaccine rollout seemed to be fairly quick. One thing that I know certainly impacted my family was having Dr. Kizimea Corbett, who you may have heard of. She was a lead scientist on the Moderna vaccine, actually say on national television I understand the concern. We have been working on this vaccine since SARS, as Erin mentioned. I, as an African-American scientist, would not participate in any type of trial that would do harm to my family, my ancestors. And I think that compelling testimony from her really has turned the tide in terms of some members of our population. And again, someone brought up, we have to go where people are too. And so one of the reasons I think that that number is low for African Americans receiving the vaccine are the frustrations of where to get them and how to use technology that might not be available in everyone's home. And then the frustration of not being able to get an appointment. And so I'm proud that my church has opened its doors, and at the end of the month, we have a partnership, a collaborative partnership of nonprofit organizations. We have 1,000 community members signed up to receive vaccines that day, and we are having in Central City, Des Moines, which and all they needed to do was call my church and make an appointment. We had to sign up to, it was fairly easy to use. Those, I believe, are techniques and methods that really hopefully will be mirrored throughout our state and throughout the country in terms of going where people are.
Mm-hmm. Well, Claudia, that kind of brings us back in a way to what you were saying at the end of the very first segment when you were talking about transportation issues or seasonal workers who are here for a short period of time and then they move on. And that's got to be a huge problem for access, not only to healthcare if you're ill, but to a vaccine should you want to get one.
Yeah, it is. I mean, it plays out directly. Just today, I was speaking with a group of people at the state, and we were thinking, so where if we want migrant farm workers to get vaccinated, where are our options? Well, could they get vaccinated before they enter the country? Could they get vaccinated once they cross into Texas? Do they need to get vaccinated once they're in Iowa? And looking at all these different points, and the H-2A visa workers actually don't stop in Texas. So there are just so many logistical issues. But but this comes back to a point that Jackie's made and Martha has made, is that we need to deconstruct the systems and the structures that create these barriers. And yes, we may not be able to do that in time for the vaccine this summer, but that's where our minds need to go. We need to use this experience, this concrete examples, concrete evidence, that we need to wind it back and really start looking at the structures that actually create these barriers. The one thing I wanted to say before we close is following up on something Kimberly and really Erin has said, and a question you asked Kimberly, which was, what's an anthropologist doing in a medical school? And I have to say that, I teach a course called Interprofessional Education for medical students. And so it's how to work with people in different professions. And as an OCMed doc, I do that all the time. But, I work with Kimberly, and now I'm working with Erin. And Kimberly is teaching me to rethink how I think about my patients, how I think about other people, and to be able to meet people where they are and to try to think from the perspective of the people that we're trying to either help or to study or to engage. And it's really almost like going inside out. It's hard to describe, but it's, the value of having people like Kimberly and Erin in a medical school is just limitless. It's a game changer, I think. And especially now that people are beginning to more highly value community engaged research and making that the starting point for thinking about any program, any project, or any new initiative to help people.
It's great to hear. And I didn't just ask the question out of curiosity. I was an anthropology major, Kimberly. So I'm kind of thinking, wow, how did you find your way into that? Personal interest in my part. But We have a couple of questions that came from listeners tonight. And one of them is, I don't know who might like to address this. Do you believe that precision medicine is the next best step for addressing inequity in health for vulnerable populations? And if so, why?
Could I would like to maybe answer that. One of the reasons that I was excited to join this panel discussion tonight is because every single person who has participated tonight is really impacting the future of medicine. I affirm what Dr. Corwin is saying about how important it is to have all disciplines in the field of healthcare, so to speak, not just medicine, but healthcare in general. I particularly have an interest in brain health or mental health, but I think it's important that we understand, and I have an orientation presentation that I do for new providers when they begin work at my healthcare system. And I ask them to think beyond cultural competency when treating their diverse patient population, but more cultural humility. We want people to be able to be self-reflective, and that cultural competency isn't a one-time class. It's not a one and done. It's a career-long, it's a lifelong journey to being able to understand the diverse perspectives of your patients, their cultural background, faith traditions, and how they present to the healthcare encounter. And so in that way, precision medicine, not so sure about that term, but I believe cultural humility might be what we're looking for in our future healthcare providers.
Mm-hmm. Well, there's one other question, and that is the University of Iowa a partner with the NIH All of Us data collection project? Would you know, Claudia, or any of you? Apparently, this is a project that is meant to address some of the comorbidity issues that have impacted many minority populations. So in regard to gathering data from folks here in Iowa, I guess I don't know the answer, so.
I don't know the answer.
Yeah.
We are involved. I can't remember if we are just a recruitment site or if we're involved in other ways, but I work with some of the genetic counselors. I know there's at least some involvement with UIHC and the All of Us program.
The library is also a partner with All of Us in thinking about health literacy and getting that out into communities through libraries and other forms of outreach.
Great, great. Gosh, well, I'm afraid we've come to the end of the program. So please let me thank Jackie, Aaron, Kimberly, and Claudia for being with us. And thanks also to each of our earlier guests. All WorldCanvass programs are available on iTunes, the Public Radio Exchange, and the International Programs website. And you'll also be able to view this program on YouTube. So I hope you'll join us for the next WorldCanvass on April 16th, when our topic is Gandhi at 150. Until then, for University of Iowa International Programs, I'm Joan Kerr, and good night.